Next presentation is going to be explained by Mrs. Virginia Weiss and Dr. Dorothea Munchen, so both working in the Department of Neurosurgery in Hamburg in Germany. Mrs. Weiss is a nurse from our staff, and Dr. Dorothea Munchen is our intensive care coordinator in Hamburg, and they will be talking to us about a joint venture between Kenya and the Neurosurgery Department in Hamburg, working on children and adults, and here specifically on shunt survival. I don't know, there were some issues for both of them to join the session because they're both on the intensive care unit right now. So it's possible that they will not be able to join. I'll check. So Virginia and Dorothea, are you here? Okay, I don't think they're here. So I do have the presentation because we did prepare in case of such a situation, seeing as they're on intensive care. So I will take over right now to present their work as best as I can. So here we go. Is this perfect? Can everybody see the screen correctly?
Yep.
Yes,
I can see
perfect.
the slides. Thank you.
Okay, so this, like I said, this is a joint venture between, and also just this is a presentation, it's a double presentation, so it will be 14 minutes long, not to worry because of the timer. So this joint venture carries the name of Savubona. It's a series of missions that were started as a cooperation between the University Hospital of Hamburg and the Mombasa General Coast Teaching and Teaching and Referral Hospital. So started as a nonprofit charity to go help local neurosurgery departments in Kenya. So the point of this joint venture was to introduce new neurosurgical techniques, to share medical equipment while trying to find solutions to save resources, which is a very big, an issue that most people in the Western world are not familiar with, but on other continents and in more low-income or mid-income countries, this is a very big issue. Then to continue also with neurosurgical education for the local professionals and to establish a permanent exchange program for neurosurgical residents to come and learn techniques in the Western world. So the first mission started in August 2021, so led by Professor Oertel, who's the head of department of the neurosurgery department in Hamburg, and also the chairman of our research committee. And this mission has been going on every year. So this year, our trip is planned also in end of July. So we will be continuing this program with the Coast General Teaching and Referral Hospital in Mombasa. During these missions, so there's one part which is very clinical part, operating, so every day for hours and hours. But there's also the point is to be able to follow up on the patients that have been operated on. So these are also then it's all outpatient follow-ups. So this is a first obstacle that, Virginia, you're here. Would you like to take over the presentation? Yes. Great. Virginia, can you?
Yeah, I can hear you. How are you?
Good, and you? Thank you. Thank you for joining.
Yeah, I'm sorry.
It's not a problem.
Yeah. Yeah, please, maybe you can also continue because Doro is just taking over. Okay, so
yes. I'll just continue then, but thank you for joining us.
Thank you.
That's the first obstacle that we face in these missions, the follow-ups, because we don't have the same established structures as we do have in the Western world. So it's very difficult to try to contact patients either by telephone or just even by word of mouth to be able to bring patients back into the hospital. Some of these receive routine checkups from the local doctors, but it's also important to be able to have more of an expert opinion. So that's where the Hamburg team comes in. Also, a big issue is with diagnostic imaging. We're used to in Europe or in America, you can always get a CT scan, MRIs as much as you want, but this is a big issue. So diagnostic imaging is a precious resource, which has to be, which is very limited. So here you have a little overview of the 4 last missions. So how many patients have been operated on, and so also always if they're adults or children. So over the 4 last years, so we have treated in total 94 patients. And so about 2/3 of them adults and 1/3 children cases. And also, it's not only just to operate it, also a lot of patients can come in so as outpatients, so they're not being operated on per se, but still receive care or the imaging that they need. And here is a little overview of the follow-ups that have been done. So from the first mission, with 6 patients, only 3 were followed up. And you can see, so this is a very, like I said, it's an obstacle that we're confronted with, is being able to follow up on these patients, because operating is one thing, but if you cannot see, if you implant a shunt, for example, if you're not able to control it regularly for infection, or if you can't control if it's flowing correctly, that is going to be a very big issue. So this is also a very important part of this joint venture between Germany and Kenya. Here specifically, we also had a lot of pediatric patients with hydrocephalus. Etiology, so they're very different etiologies, so either congenital, post-infection, or also associated with myelomeningocele, or with myelomeningocele, and then a few forms of more rarer hydrocephalus with occlusive, or even associated with syndromes like the Dandy-Walker syndrome. For the operations that were offered to these patients, so a patient who comes in with hydrocephalus, specifically a pediatric patient, shunting is not the only solution. You can also perform ETV, you can perform fenestration. So those are also operations and procedures that have been offered through this joint venture for these patients. So they have the opportunity to receive an ETV, which, depending, of course, on the etiology of the hydrocephalus, can be life-saving, and also have the advantage of not having a patient that is shunt dependent for the rest of his life, because as you all know, shunt dependency can be very difficult. It's a mechanical piece. It's like a car. Sometimes you'll have to bring in your car to change the tires. Sometimes you have to change the oil. Sometimes you have to change, well, a lot of things on a car. And so we face these same issues with shunts, and specifically in a setting where diagnostic imaging is not possible on a regular basis. These issues will be a lot more present and complicated to deal with, which is why offering endoscopic procedures where patients are non-shunt dependent is a very big advantage. So from the pediatric population that was operated for hydrocephalus, we have several follow-ups. So of the 14 children that received a procedure for hydrocephalus, only 6 of them could be followed. As you can see, also some of the patients are deceased, and some of them are also not reachable. So we come back to the same issue that I mentioned before. So follow-ups from the 3 first missions, with then also VP shunting. It's the same thing. It's very complicated. If you cannot have access quickly to a shunt or to a diagnostic imaging, you will not be able to see if any issues come up, and then patients, if you cannot prove that there's a problem, the patients can also not be treated. So the take-home message from this part of the presentation is the most important factor for the later outcome will be the cause of hydrocephalus. So that this doesn't change from. Time is up. It's okay. Well, I'll just continue with the second part of the presentation. But so this is very important, and this shows the importance of having correct diagnostic imaging that is interpreted correctly to be able to then offer the best solutions for the patients. So if they're shunt dependent or non-shunt dependent, will have a very big impact also on the later outcome. So now just a few cases, so which Dr. Munchen would have presented, but she's right now busy with the ICU. So first case of endoscopic hydrocephalus surgery, we have the patient, which is photographed here, who had aqueduct stenosis and obstructive hydrocephalus, which made him a prime candidate for endoscopic third ventriculostomy. So the patient was operated on in February of 2022, and then had first follow-up 1 year, almost exactly 1 year later, and then a second follow-up 2 years after the operation. And in this case, so with the proper diagnostic imaging, with CT scan, we were able to prove that the ventricular width had decreased and that the patient had proper and good actually neurological development. So as you can see here pictured on the left, we're also make use of portable ultrasounds, which is often the only resource available in low income settings, which is also a very practical imaging technique to have. But of course, it's better with regular CT or even X-ray imaging. Another case of shunt revision. So comparing the ETV and the shunts, which are the different procedures that are offered to patients with hydrocephalus. Here we have a patient who had malresorptive hydrocephalus with the initial surgery of placing a ventriculoperitoneal shunt in November of 2018. So this was not placed by our team in this joint venture, but was placed by a local team. In 2022, it was noticed that the patient needed a surgical revision of this VP-Shunt, which was done in February of 2022, and then with a follow-up 1 year later and a second follow-up 2 years later. And here we could notice that the patient had no clinical improvement. He suffered of seizures and also showed signs of overdrainage. So this is a very important, that comes again to our big issue of being able to have access regularly to diagnostic imaging, to be able to prevent these problems, or if the problems do appear, to be able to treat them in a timely fashion. So here to summarize the main differences that have been observed between Kenya and Germany, but I think we can also generalize this to some extent for a lot of, comparing a lot of low-income countries with a lot of high-income countries. First big issue is there is no social security or no state-financed social security in a lot of these countries, which means no health insurance, no care insurance also for after the surgical procedures. Another big issue is financial problems and poverty generally. So not being able to, when patients have an issue but are not able to finance the necessary procedures, the necessary life-saving procedures, we also are confronted with a lot more hygiene and infection problems in the settings, not from the operation directly, because we still have some very sterile and very good settings, even in low-income countries, but it will affect the post-operative care of patients if they're not the proper hygiene situation. Another big issue which we are confronted to here in Kenya specifically was sort of segregation of disabled patients. So it's a very taboo subject. So disability is a very taboo subject. So this adds on to the stigmatization of these patients before and also after the operation. So thank you very much. I think we're done a little bit earlier than planned, so that's good. And thank you for hearing me present the work of my colleagues.
Thank you.
Thank you, Nathan. Virginia, do you want to add anything to that lovely presentation?
I just say thank you so much. He presented exactly how we put it. It's only that in Kenya, it's really the people, they need more medical care and the support. Thank you so much.
Great, thank you. So Nathan, maybe I can ask you a question. So in South Africa, and I don't know the origin of the term Sawubona, the name of the foundation. Sawubona is a very profound greeting in South Africa. It's a Zulu word that means I see you. And it means I see you in a very deep and significant way. And I guess my reflection would be you made reference to the local teams, and neurosurgery in my experience is actually quite well developed in Kenya. There's high levels of neurosurgical expertise, obviously not very uniformly spread around the country. But I'd be interested in the sort of the interactions between the Sawubona Foundation and this obviously very committed effort on the part of a German NGO to kind of build services in Kenya, and your interactions with local clinical teams and building capacity in Kenya.
I think I'll refer the question to Mrs. Weiss, because I think she'll be able to answer it a lot better, being herself a local from Kenya and working in Germany. Virginia?
Again, please, the question.
Virginia, it really sort of relates to the experience of as the Salbona Foundation has done this clinical work. Neurosurgery is reasonably well developed in Kenya. So what are the interactions between the foundation and the work you do and the local neurosurgeons and building capacity to empower local clinical teams?
Okay, so my name is Virginia. I'm born and raised in Kenya myself. So when we started the foundation, first we went to Zanzibar, where we found also 3 years we went to Zanzibar, then we came to Kenya. Over 4 missions we have been into Kenya. So this challenge is also the equipment. We find the equipment that are not there. Most of the nurses, they don't know to handle the post-care after the surgery. So there's a lot to interact to give the information back to the locals. And also because some patients, even they don't show up in the hospital, because as we said before, it's like a taboo. If you have a disabled kid or a patient, they are just kept at home, not to come to the society, because it's seen like disgrace for the society. So to challenge these parents to bring their children to the hospital is also a big deal. And also the big thing is also the insurance. You can only get treated if you have an insurance, and which is only like $5. And most of the people, they can't afford this insurance. So for example, when we come there, the volunteer work is free, but because the hospital say they can only handle the patient with insurance, so you find some cases are not handled because of just poverty of $5 per month.
Okay. Wow. Okay, thank you. So there's clearly a big opportunity there to make a difference.
Yeah.
Thank you. Nathan, I think it's over to you to do the legend interview with Mike Steinmetz.
Exactly. So unfortunately, I was supposed to interview Professor Mike Steinmetz, who's the department head of the neurosurgery department of the Cleveland Clinic in the United States. Fortunately, I've just received word that Dr. Steinmetz is indisposed at the moment, and the organization team has then just suggested to move on to the next session. So excuse if everybody will excuse us for this change of program, or several changes of programs from the research committee session. But thank you everybody for joining in and allowing us this opportunity to present some of our starting and ongoing work with our more junior and more senior researchers.
Great. Thank you so much for the opportunity to be a part of this.
Thank you very much. Yeah.